Okay, it's 9:30, so I got some announcements. Okay, I've started to write the exam. I'll have it written tomorrow. On Friday, I'll email you all the breakdown like I did before. Okay, I've decided to cut some material in the muscle chapter, which is a-okay because we've got plenty of material for the exam. So I'm going to let you know I got to update chapter 6's study outline, which I haven't had a chance to do. So if I go to the syllabus, I can't remember which. Okay, so we are right here. All right, we're going to finish this up hopefully today. And then next week I said in lab, just make sure you wear a t-shirt or a shirt you can roll up so you can get a blood pressure cuff on your arm. Okay, but there is no lab quiz. All right, so we get a little break there. So back on muscle physiology, I started working on this yesterday and I have to update it. I'm going to be crossing off this stuff right here. Okay, but I haven't had a chance to change this yet. All right, so that's the update. The other update is, of course, I've got all the lab report scores in. And so let me refresh it. Oh, I didn't pull it over. I put it into my Excel spreadsheet, but I didn't bring it over to the server. I do have them. I'll get them posted. I just forgot to do that yesterday. But I was really happy with the lab reports. The mistakes that people made were basically, if you didn't follow the guidelines, the grading guidelines, and remember that they were back here. It's kind of too late now, but back here when we had the blood glucose lab, which my goodness, the semester's going by. Blood glucose. So it was this thing right here. Okay. If you didn't follow that, that's where you lost points for sure. There were some grammatical sentence structure clarity issues and stuff like that. Usually those are minor, but that was the main thing. So next week, when I assign the blood pressure lab report, I don't have it with the blood pressure hyperlink. I have it up here and I'll go over it in lab. This thing gets in the way so much. Get out of the way. There, guidelines. Click here for blood pressure lab report grading guidelines and look very similar to the blood pressure grading, the blood glucose grading guidelines. So I'll have that again. All right, so make sure and follow that. Definitely. Any questions about any of that? Okay, we are officially mid-semester. Isn't that a scary thought? March 2nd. Woo. All right. So today we're going to finish off the muscle stuff and I cut some material, but what I did forget to do is after this slide. So if you've got your PowerPoint up or looking at it or you've printed it out, please go back to here. So we ended up, I think we ended up here, but we got to go back. All right. So go back to this slide, go back 1, 2, 3, 4, 5, 6, 7, 8, 9 slides. And this looks a little different from the one you've got because I changed it. It basically, yours said sliding filament theory of muscle contraction. What I forgot to do, and I'm going to ask it on the exam, so I want to make sure and do it, is step by step go through from where acetylcholine is released to a muscle is contracting. So let's write it down because I'm always going to ask this on an exam. And I do this because the nursing program has lots of exam questions where the sequence of things you must do are very important. And if you screw it up, you get the question wrong. So I like to get you to practice about sequence of things you must do. So if we start with the motor neuron, let me check my pen here. All right, so the motor neuron releases ACH into the synapse. Okay, so it all starts with that. And then ACH binds to a receptor on the muscle cell. So what is that receptor on the muscle cell? Skeletal muscle cell for acetylcholine. Nicotinic, cholinergic. Okay. Now, when that happens, you get an action potential in, well, I'm a step ahead, hold on. That causes this ion channel or these ion channels to open. Sodium. Okay. Sodium floods into the cell. You have an action potential. All right. Let me make sure. Let me count my steps correctly so I didn't miss a number. Okay, that'll work. Sodium floods into the cell. Sodium goes down the T tubules. Okay. And the T tubules go next to this thing called the sarcoplasmic reticulum. So this ion is released from the sarcoplasmic reticulum. Yep, calcium. Calcium is released from the sarcoplasmic reticulum. Now, this calcium is going to go down to a very microscopic scale, the sarcomere scale, and it's going to bind to one protein on actin. Is it the long T word or the short T word? It's the short T word. Binds to troponin, which is on actin. And since troponin is attached to tropomyosin, that event causes tropomyosin lifts off the active sites on actin. Okay, once the active sites are removed, well, not removed, but cleared, the myosin heads can grab on actin, form a cross bridge, and pull. So now, I have to write it up here a little bit because of that. Myosin heads grab, and that's called a cross bridge. And I know I'm writing small, but I'm running into the bottom of my tablet here. Grab active sites and pull. And obviously that's got to happen over and over again, grab, pull, but in its essence, the muscle contracts. So that is, let me put it here, I don't have the room. That is the muscle contracting. All right, so those are the steps. So in a future exam, which will be next Friday, I'm going to have all these steps all mixed up with different letters. And you're going to have to rearrange the letters so that they're in the right sequence of events that happen. And then choose the right multiple choice answer that has the letters all in the right order. Okay, but that's definitely going to be on the exam. It's kind of like a flow diagram. All right, except, I mean, you can just practice writing this out just like this. Okay, any questions on that? Because I realize I skipped that slide and it's a very important one because I'm going to ask a question on the exam and I want you to get it right. Okay, so now we can go back to where we were. So we went through that, 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 went through that. Ah, this is where we left off. So let me move this down here. So I guarantee you've probably experienced this, the sleep twitch. All right, as my husband calls them, the Jimmy legs. Anyone who works out or is an athlete, this will happen to you sometimes the night after you work your muscles heavily. It can just happen in general. So a sleep twitch is a myoclonus or a myoclonic jerk or a hypnagogic jerk. They have many names for it, but it's a sleep twitch. You twitch yourself almost awake. So it's involuntary movements as you start to go from light sleep to deep sleep. Okay, so there's lots of theories and everything, but the physiology is what's happening physiologically in your body is GABA wants to take over, to quiet your mind and paralyze your skeletal muscles. So when you're at that border between non-REM and then deep sleep REM, GABA is trying to take over. And it's not perfect, all right? It takes longer for some people than others. And what can happen is, as GABA is trying to make that transition of taking control, that's when you have that little sleep twitch, because GABA hasn't firmly gotten a hold of you yet, right? Some people say your body perceives, your mind perceives that you're literally falling to sleep, you're falling and then you jump to catch yourself. I don't know if that's true, but it does involve GABA. So you've got a cat. I saw this on TikTok and I love it. Let's see if I can get it to do it again. Hold on. There we go. So here's the cat that's twitching. And that you've seen people do it. I've seen animals do it, but I don't often see them jerk themselves awake, but that would be all right. So that's your classic myoclonic jerk. All right. So we've all experienced it and probably seen it in our pets. All right. So from here, we talked about some muscle disorders, and I kept really close to the textbook. The textbook does a really good job of talking about various muscle disorders, ones that you're going to see on a regular basis as a nurse. So let's talk about muscle fatigue. You experienced it this week in lab, so now you have a better appreciation of it. You felt that lactic acid burn and things like that. So what's happening when you push your skeletal muscles like that, like you did this week, is you deplete oxygen. And that means you will, let me get my laser pointer here. Probably this is okay. Yeah. Okay. So you're depleting oxygen. You're depleting up your ATP stores. You're depleting your glycogen. I doubt in 100 seconds you actually depleted your glycogen. It's going to take about an hour or so of continuous, vigorous muscle activity for your muscles to really blow through their glycogen stores. But you certainly use a lot of your muscles' respiratory pigment, myoglobin. Now, what you accumulate is what you felt on that experiment today, Monday, Tuesday, Wednesday. You accumulated, it's not going forward for me. There we go. Some CO2 waste, which you just breathed out. That was fine. You accumulated a lot of ADP that split off because the myosin grabs a hold of actin and pulls. That uses up ADP. Lactic acid. How many people felt in your forearm flexors that lactic acid burn? Right? Okay. And then you accumulate phosphates, because what's happening is ADP, which is used for the grabbing and pulling on actin, the P is for phosphate. And so as you use up ADP, the phosphates cleave off. All right. And so you have an enzyme in your skeletal muscles to replenish that ATP, to stitch the phosphates back together again. And it's going to be clinically relevant to you. So while we're talking about building up of lactic acid, I'll go back to my pen here. Okay. How is lactic acid removed from the bloodstream? How come your blood didn't go acidic in that experiment this week? Cori cycle in the liver. Very good. You didn't delete the hard drive after that last exam. Okay. So phosphocreatine. Okay. Phosphocreatine, it's a natural molecule in resting muscle. It's needed to convert the ADP back into ATP so that you can break the cross bridges and then pull, grab again, break that whole cycle we talked about, the energetics of muscle contraction. So it allows a phosphate to be added to the diphosphate molecule and make it a triphosphate molecule. So this is already in your muscle. Now, I've got up here creatine supplements. People can buy these supplements and take them, bodybuilders or athletes or whatever. And it does kind of improve your muscles, but what they believe is you're putting down new muscle fibers, and that's not true. You have stem cells which can produce muscle fibers, new ones, but this does not do it. All this stuff does is make your muscle fibers store water, which makes them artificially seem bigger. So there is no shortcut. The only way to truly improve muscle mass is to actually work them. This stuff right here is just a cheating short step. All right. You're just taking on water in those muscle cells. But where am I going with all this? Creatine phosphokinase, and I like the CPK because creatine phosphokinase kind of helps a little bit, is an enzyme you have in your skeletal muscle. You have it in your brain. You have it in your heart. Probably have it some other places too. And is needed to convert creatine, this substance, into phosphocreatine, which donates the phosphate molecules to make ATP. That's great. Why is it clinically relevant? Well, there are different tests you can perform on someone to determine if they've had an ischemic event. An ischemic event means they've lost blood supply to a body tissue or organ. So you can lose blood supply to almost anything in the body, to your brain, to your heart, and other tissues. And it can indicate what will happen is, you know this already from metabolism. If there's an interruption in blood supply, that means an interruption in glucose supply, which is bad, an interruption in oxygen supply, which is bad. Tissues that don't have oxygen can't respire aerobically. They go to anaerobic respiration. And we all now know that only produces a little bit of ATP and some lactic acid. All right. So that's an emergency in the brain and the heart. Skeletal muscles can tolerate that a little bit, like you did in lab this week. So there's different isoforms of CPK for different organs that can elevate when the tissue has been damaged, most likely from a loss in blood supply. So isoform CPK, MM, is elevated when you have muscle damage. It doesn't necessarily mean from just loss of oxygen supply. It could actually really be muscle damage from something else. People who have muscular dystrophy, or we're going to talk about a lot of muscle disorders. This enzyme can be elevated, and that can be an indication that the muscles are damaged, possibly permanently. Then in the brain, CPK-BB. So when I think BB, I think all brain. When I think MM, I think all muscle. Well, if you have brain damage, this isoform will be elevated, and you can test for it. All right. Someone comes in, you suspect they've had a stroke. Lots of things are going to be done immediately. They're going to go for a brain scan. Okay. You're going to take blood. You're going to look for elevated things that would indicate a stroke. Okay. And some other things as well. You can do an EEG and all those things. All right. Now, CPK MB, something in between, is when you've got damaged heart muscles, often from a heart attack or a myocardial infarction, where you've basically lost blood supply to a part of the heart, and this dark part of the heart indicates those cardiac muscle cells are damaged from the lack of oxygen and glucose, possibly temporary, possibly permanently, and that would be a problem. So you can actually measure these, and it takes a little bit of time for those to build up. But let's say you have someone that comes in, you suspect they've had a heart attack. Okay. All kinds of tests done. EKG, draw blood for enzymes and proteins that might be elevated, and some other things as well. And then you can confirm or deny. Once you know what the problem is, you know how to fix it. All right. So that is why I went to all the effort of talking about creatine phosphokinase. Okay. Now that I said the creatine supplements you buy online or from general nutrition stores doesn't actually produce new muscle fibers. It doesn't. Just makes them store water. You can actually replace some muscle fibers through this process. So you've heard of adult stem cells, perhaps. We have them in our muscle. We have them in our bone. We have them. Fortunately, we don't really have good ones for nervous tissue, but we have them all tissue types in our body, and it can replace damaged tissue. So satellite cells are muscle stem cells, adult stem cells. They can repair damaged muscle. All right. Do not memorize this. It just shows you that you start with a satellite cell, and it goes through a mitotic event, and you produce new muscle fibers eventually. It takes some time. I don't know exactly how long. All right. So this is how you repair and replace damaged muscle. And so that happens on a regular basis. Now, myostatin, for every action, there's an equal and opposite reaction. So myostatin inhibits satellite cells to decrease muscle growth. Because lots of things in your body are remodeling all the time. In your skeletal system, your bone remodels all the time. All right, changes shape. If you've ever broken a bone and you've heard and watched the x-ray for the bony callus that forms, that does not always stay that way. Eventually it will remodel, and that callus gets smaller and smaller and smaller. Your muscles are remodeling themselves all the time too, depending on how much physical activity and work you put them through. If you work a lot of muscle, they will respond in kind. Okay. And if you don't work muscle, they'll atrophy. We'll talk about that. So myostatin kind of keeps this process in check. Now, the reason I have a bulked up dog and cow is, well, as people age, their muscles tend to atrophy, mostly from disuse, unless they have a neuromuscular disorder, okay? So that can happen. And another thing that happens is their myostatin levels start to rise, and that could play a part in it. Now, we've come a long way. Doctors used to be very, very careful if you're elderly about working out. Now they're like, with permission and guidance from a doctor or a physical therapist or something like that, continued physical activity is actually really good for people as they age, okay? Especially women who are prone to osteoporosis. The more you work your muscles, a moderate weightlifting regime, the muscles pull on the bone. The bone responds to that force being put on them by thickening. So a little bit of weightlifting, moderate weightlifting, can actually delay bone thinning with osteoporosis. So doctors are now saying, okay, moderate exercise is actually pretty darn good for you. Well, anyway, so what's happening here? In some people, it will be rare. There's myostatin inhibition. So some sort of genetic condition. So they will breed beef cattle so that this happens, so that they have more muscle on the hoof when they go to slaughter, okay? And you get more muscle out of a cow. This dog just happens to have a genetic congenital problem, was born with myostatin inhibition. And so you don't have inhibition of muscle growth, that is taken away, and the muscles overgrow. Every now and then, you'll see a person born with this condition. What's the problem that you can envision with this kind of condition? What kind of problem would say a person experience? They're going to be Hulks, right? Yeah, smash. Any problems you can foresee with that? Think about acromegaly. You've got gigantism, okay? Excessive growth of bone and muscle and everything. What about the joints? Are they going to suffer damage? Yeah, possible early arthritis and permanent joint damage. Hell yeah. Okay, because that's a lot of mass to keep on those joints. The joints aren't thickening in response to that, not quickly. So that's not a good thing. Okay, muscle atrophy is loss of muscle mass. Okay, anyone in here ever broken a bone and have it in a cast? Okay, when that cast came off, was it an arm or a leg? Was it an arm? Did you notice when the cast came off if there was a difference in size of the arm that was in the cast? Because while it was in the cast, you were told to take it easy, right? And to not use that arm as much. Well, just like anything else in the body, if it goes without use for too long, it's going to atrophy. It's almost like the body's way of saving energy. So that can happen. And so this is a person who obviously the left leg is a little thinner than the right leg. You'd have to really look at it. But that left leg was in a cast for an amount of time. I remember when Dr. Pryor had his arm in a cast. And he was pretty active before. And he wore it for, I don't know, bone heals pretty good if it's not a complicated break. About 6 to 8 weeks, 10 weeks if it's not complicated. That's really not that long, okay? But in that time, your muscles can atrophy a lot. All right, so if the bone is healing and you're not using it as much, the muscles will atrophy. If you're just a couch potato, like a lot of us probably did at the beginning of COVID because we couldn't go out, some people gained weight, but maybe their muscles atrophied. If you have injury or disease of that muscle, like myasthenia gravis, we've talked about that. Muscular dystrophy, we'll talk about that. Or a nerve damage, like amyotrophic lateral sclerosis, I'll get to that later, where for one reason or another, the muscle can't contract or the nerves going to the muscles are not communicating with the muscles are going to atrophy. I have a stepdad in Ocala. I'm going to visit him on spring break, and I'm kind of bracing myself because every time I see him, and it's not often, it's like once a year, he's atrophied more because he has got oculopharyngeal MD. Okay. And so his nerves are not communicating with his muscles correctly. And so he can't use them. And I've watched this, a very active person eventually lose. First, he started getting weak in the legs. And so he needed a walker. And then it got to the point where even his arms were getting weak. And so he's restricted to a wheelchair now. And now but then he could, use his iPad. But now he's got one arm that's useful and the other arm is losing strength. So it's closing in on him. All right. Leftover time, MD will take away your voluntary use of your skeletal muscles. So his muscles have atrophied. I could probably pick him up. He's probably light as a feather right now. Okay. So, all right, let's talk about some other disorders. Okay, muscle spasms are involuntary muscle contractions. And this is not a problem necessarily in the brain. The kid looks like he's having a seizure, but he's not. He's just got these little twitches. And I have an aunt that has that because she's on some medication. And she's got dyskinesia of her muscles. So she'll make little twitches in her face. Okay, that's a muscle spasm. I've seen commercials for people who are taking a drug and it causes dyskinesia and they have to take another drug to help with that. But so this kid's got this, all right? But it could be an eye twitch or a grimace in their face or something else. All right, these people are normal. Don't treat them like freaks, okay? They cannot control this. This is not their fault. Now, a muscle cramp you probably have experienced. If you are someone who works out on a regular basis, sometimes after a heavy workout, it's usually due to depletion of salts from sweating, you'll get a muscle cramp. And this guy's getting a cramp in his calf muscle. See that? Have you ever like woken up in the morning and stretched and then your toes locked in a spasm? Your felt hurts, doesn't it? Yeah, and it goes away, but that's a muscle cramp. All right. So this is involuntary muscle. I'll just call it a cramping due to excess muscle activity and loss of salts from sweating. Okay, so people who have cramps, they're encouraged, Gatorade, eat a banana, has nice phosphorus in it, things like that. Reduce these if you experience them, all right, because that's usually what it is, and it goes away. This not necessarily goes away. It could be continuous. This is temporary. You've done something to your muscles to make them a little happy. Treat them light, pamper them, and they'll be fine again. All right. So cramps go away. These do not necessarily go away. Okay. Some more. A muscle sprain. So what that is, think about this. One of the most common athletic injuries you can have, especially if you're involved in a sport where you get lateral hits to a knee, because the knee joint is supposed to be a hinge. This is its movement. It's not supposed to move laterally. We have two stabilizing ligaments. The anterior and the posterior cruciate ligament, cruciate because they cross, is meant to stabilize the knee joint. But if you get a swift hit to the side, you can tear that sucker, okay? So a muscle sprain is basically overstretching or possibly tearing of a ligament. Overstretching or a tear in a ligament. So remember, a ligament holds bone to bone. Now these tissues, ligaments, are very tough. It takes longer if you overstretch a ligament and sprain it. It could take months, 6 months to a year for that to heal itself. Bone heals faster than that. So these soft tissue injuries are actually more long-term and require care. You're not supposed to ignore these things, okay? So the treatment is rice. Rest the area, ice it down, compress it so swelling doesn't take over, because the swelling can cause a lot of pain and damage, and elevate it so there's more fluid return from the lymph system back into your circulation to get rid of that swelling. And the worst part is you're going to have to work on patient compliance. You need to do this for this amount of time to really let this heal. Okay. If you go out and you push it, you could start with an overstretched ligament to a torn ligament. And once a ligament is torn, it's not going to heal itself naturally. You're going to have to surgically go in and maybe harvest some tissue from other places in the body and suture that together again. Anyone here, because I know I have athletes, anyone have an ACL tear? No, that's fortunate. Oh, okay. Tell us about your ACL stuff.
And I had to wear a cast.
Wow. Now, was it torn or just overstretched?
It was
It was torn. Now, was it able to, because torn doesn't mean completely torn apart. It could have a tear in it, right? Is that what happened to you? It was just torn into, but it didn't break.
right.
So you didn't need the surgery. It took a while. How long did you wear the cast?
I think 6 to 8 weeks. Somewhere around
Oh, that's not bad. So it
Yeah.
probably wasn't a bad one.
there. Yeah.
And you were young, your
I was
body
like
heals.
8 or 9.
Okay, the body heals at a faster rate when you're that age. If you're more like 20 and this happens to you, unfortunately, it's going to take a little bit longer because our rate of healing ourselves as we get older diminishes. So, okay. And did they say rice?
Yes, it did.
Okay. All right. So this is very common. The other very common thing you're going to see is a muscle strain or a pulled muscle. So this is something you could see in people who are pushing their muscles too hard. They're abusing anabolic steroids, and so they're putting on a lot of bulk mass. Or maybe they got something else going on. Maybe they're myostatin inhibited, but they're putting on so much mass that the muscle can actually tear. All right, it can't support the tension that the muscle itself is generating, and so it can tear. So a pulled muscle is a well, it's pulled, overstretched muscle or torn. Now, muscle, once it's torn, it's actually very difficult to treat that. I mean, trying to suture muscle together doesn't work so well. It can be done, but if you try and suture together two pieces of a ligament, it's going to hold better because that's a very tough connective tissue. Muscle, not so tough, harder to suture together and keep it together. All right. So you'll see athletes or other people who kind of overdo it, and that you might see this kind of thing. A muscle clonus is different from the sleep jerk. This is actually a problem. When the muscle, when the nerve cells that control the muscle are damaged, so the nerves, all right, causing the involuntary muscle contraction or spasms. So now we've got nerve damage, and I'll circle the nerve. When nerve are damaged, that's a problem. We don't have a lot of good treatments because once nerves are damaged, they can heal. Okay, nerves can heal. It takes a long time. It could take years. Okay, that's how long it takes. So caused by lesions on motor neurons, could be a problem in the brain. Again, that's a problem if it's in the brain, like multiple sclerosis. In multiple sclerosis, we talked about it. Your immune system attacks your myelinated sections of your neurons and damages them. That causes scar tissue, which are the scleroses. Cerebral palsy, often due to lack of oxygen during birth. Huntington's disease was a genetic disorder. And so a lot of things can end up causing this. But it is an abnormality in the nerves that's causing this. All right. So I have, now as nurses, you're going to be able to learn all kinds of clinical tests that you could do, easy things. And so here's a clonus. The nerve is the problem. When you push on someone's foot, like I'm pushing on my hand, okay? My hand feels that, the muscles in my forearm feel that, and they can provide some resistance, but I'm not doing this. Okay, that's not happening. That would be abnormal firing of a nerve to those muscles. And that's what you're seeing here, is when resistance is put on the plantar surface of the foot. The trembling you see in the muscles is because of a nerve problem. It shouldn't do that. Test yourself at home later. Take your shoes off, put some resistance on the bottom of your foot. It shouldn't go like that. All right, so that's abnormal. Okay, I put this in because the book had it in. Dermatomyositis. So I put it dermatomyositis. The situs, myo means muscle, and itis means inflamed. So it is inflammation of the muscle and the skin. Interesting. I don't know how those two are connected, but the derm is for skin. All right. So 1 in 100,000, that's actually pretty darn common, more in women. So you have muscle weakness that progresses. It affects muscles close to the trunk, so hip, shoulder. And for whatever reason, and I didn't look into the details of this, it causes skin rashes that are pretty severe. All right. So like some comes in with muscle weakness and skin rashes. Like, well, do you have what? I don't know. There could be many skin conditions. All right, that could cause this. Now, since it's an inflammatory condition that leads to the muscles weakening, you can take anti-inflammatories like the corticosteroid prednisone. We've talked about that. Taken too long, it works great, but you can't stay on it long term. You have to cycle on it, then off it, then on it, then off it. So your adrenal gland doesn't shrink. There's non-steroidal anti-inflammatory drugs, ibuprofen, acetaminophen, things like that, they're not a steroid. Anyone know a downside of NSAIDs? Increased bleeding. Yes. And I'll put rough on the liver. Read the side of an acetaminophen bottle. All right. Don't take if you have a clotting disorder. Don't take if you've got liver problems. We read the clinical app on taking these. And you have to wear a lot of sunscreen to protect your hands because the skin is damaged. And ultra UV light could cause abnormal cells in your hand to become cancerous. So these rash hands, you got to protect them from forming skin cancer. That can actually happen. Okay, so that's in that page in the textbook. Muscular dystrophy. You're going to see it. The most common form of MD is Duchenne's MD. It is an it's a homozygous recessive disorder. So from your intro bio, that means you have to inherit a copy of this MD from your mom and a copy from your dad to show it. Most common in boys. All right. It's a homozygous. Let me clarify. Homozygous. Let me make it simple. Sex-linked disorder on the X chromosome. I am correct in what I said. A girl can inherit it if she gets 2 X chromosomes, one from mom, one from dad, but that doesn't happen as much. A boy child is XY, and whatever's on that X chromosome will get expressed. And that's why it's more common in boys. It's not saying it can't happen in girls, it does. And so we still don't know a hell of a lot about it. My stepdad has it, and we still don't know a lot about it. But it's thought to be a problem of dystrophin, which is protein in muscle that you need for muscle function. I feel like I'm waving my hands because I just don't know what causes the disorder. But it does progress. There are drugs to slow it down, but I think 50. So my stepdad has had this for 20 years and is slowly progressed, but it has progressed. But it has taken a long time. Okay. So this is not like some sort of death sentence, but what can happen is if it happens and it's diagnosed because of this sex-linked condition, you can have a child that is in a wheelchair before they should be because their muscles that are really taking the brunt of the body's weight, they suffer the most first because their most strain is put on them. And so they start losing their leg and core muscles soon. Usually their arms, like my stepdad, takes a little bit longer. All right. I'd ask if anyone knows someone with an MD. I do, but it's common enough that it's out there. Now, amyotrophic lateral sclerosis, thank God there's an acronym, ALS. Used to be called Lou Gehrig's disease because it was a famous baseball player in the 50s, but none of us were alive then. So anyway, it is a disorder in the motor neurons. And so they lose communication with muscle. It progresses over time until eventually the respiratory muscles are involved. And then it's getting close to the end. Life expectancy. Okay, so it starts in your hands and feet. My grandfather had this. me and my brother freaked. We're like, oh my God, what if it's inherited? But he had the idiopathic kind, which means they don't know what caused it, but it wasn't going to be inherited. So in his 60s, my grandfather started having problems with his hands. He started dropping things and everything. And he was a hard worker all his life, carpenter, everything, farmer. And so we all thought it was carpal tunnel syndrome. So he went for all those tests and all these things, and it wasn't that. And they couldn't quite figure it out. And eventually, with enough tests, genetic testing included, they found it was this. And they're like, I'm sorry, there's really not much we can do for you. And that is a fact. So eventually he started losing control of his arms, and he couldn't take care of himself anymore. So he had to be in assisted living, and eventually he couldn't walk anymore. He was restricted to a wheelchair. Eventually, he couldn't raise his hands to even feed himself. I distinctly remember going to this facility and feeding my grandfather because he couldn't do it with his own hands. Okay. And true to what they say, about 5 years after diagnosis, that's about your life expectancy. Some people, all right, like Stephen Hawking, who you might not know, but was an incredible physicist who died. He got ALS when he was probably 20, 30 years old, maybe 30 years old. He lived a long decades and decades past what any doctor would have expected. So he is kind of an anomaly, but then again, he was like one of the brightest minds in the world. So maybe he had things other people don't have. But they think it's loss of a antioxidant, superoxide dismutase. They also now think it's glutamate toxicity. That's a stimulatory neurotransmitter in the brain, and it's too much stimulating the brain and causing problems. Okay, so how are we doing on time? We're okay. Myasthenia gravis. This is very common. I don't think I put the stats in how many people get it for out of 100,000 people, but it's pretty common. So this is an autoimmune attack on acetylcholine receptors. It tends to go after nicotinic cholinergic receptors first. That means on skeletal muscle. Okay. But will go after the muscarinic ones as well later. I'll say if not treated. How about that? If not treated. Okay. So your own immune system goes against you and it produces antibodies. Those antibodies, the little Y-like things, attack the receptors on the muscle cells, or smooth muscle, can affect cardiac muscle, can affect skeletal muscle. What you'll see, a patient will present first with weakness in their distal limbs, okay, arms, maybe legs. They'll get some weakness, very vague at first. They'll have trouble chewing. Their chewing muscles will fatigue, all right? Even their eye muscles for blinking, right? If you do repeated blinking exercise with them, it's a real test nurses do. One eye will start to slouch. So even those muscles weaken and you'll see an eye drop known as ptosis. So it's going to be common enough that you're going to know all these things to test for it. All right. Since it's autoimmune, how would you treat an autoimmune disorder? Can you think of any things that would treat an autoimmune disorder? The problem is the immune system being too active and attacking your own tissues. What could you take to slow down your immune system? Immunosuppressants. Yes. Okay. Immunosuppressants. Okay. That's a problem because you're on immunosuppressants. You're slowing your immune system down. But what are you vulnerable to now? Colds, flu, COVID, you name it. Okay. Since we're talking about muscle disorders, let's go back and remember tetanus and botulism. One causes hypertonia, one causes hypotonia. All right, since we already covered that. So this is the end of exam 2 material. And there's other stuff after this, but you know what? It's a beautiful day. Let's call it quits early. What we will do is on Friday, we'll start the next chapter. I haven't posted it online yet, but that's going to be the cardiovascular system, chapter 7 and 8. All right. Okay. Oop. 29, 28. Back. Back. That's the one? Okay. Oh, I guess I could stop the share. Get it? Okay.